Welcome to this Step 3 review on acute kidney injury and the management of fluids and electrolytes. This video is brought to you by Roadmap to Residency. Kidney questions show up constantly on this exam, and they are a goldmine of points if you know how the question writers think. Here is the important part. Our goal today is not to re-teach all of kidney physiology. Our goal is to show you how these question stems are built, what the answer choices are really testing, and how to pick the right next step under time pressure. We will walk through the way the test frames kidney injury, the choice between giving fluids and removing fluids, how repletion of electrolytes is tested, and when the question is steering you toward calling the kidney specialist. Keep your question bank and a trusted review resource open alongside this video, because these patterns lock in when you do many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn to classify the kidney injury before reaching for treatment, sorting the cause into a problem before the kidney, inside the kidney, or after the kidney, because the classification drives the answer. Second, we will tackle the choice the test loves to put in front of you, which is whether to give fluids or to remove fluids, and we will see how the exam tests repleting electrolytes in the correct order and by the correct route. Third, we will learn to spot the STEM clues that signal it is time to involve the kidney specialist instead of continuing to manage on your own. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to classify the kidney injury before you treat it. Start by reading the creatinine trend. The question writers almost always give you a baseline value and a current value, and the story only makes sense once you confirm the kidney function is truly worsening. A single high number is not enough. You want the trend. Once you know this is an acute injury, sort the cause into one of three buckets. Bucket 1 is a problem before the kidney, meaning the kidney is starved of blood flow, which you see with vomiting, diarrhea, bleeding, or heart failure. Bucket 2 is a problem inside the kidney itself, such as damage to the tubules from low blood pressure or a toxic medication. Bucket 3 is a problem after the kidney, meaning the urine cannot drain, classically from an enlarged prostate or a blocking stone. Here is the key. The correct next step on the test flows directly from which bucket the clues point to, so always classify first and treat second. Strategy 2 is the choice between giving fluids and removing fluids, and this is where the test catches a lot of people. The whole decision turns on volume status, so read the STEM for it first. The writers plant the clues on purpose. Dry mucous membranes, low blood pressure, a fast heart rate, and poor skin turgor tell you the patient is dry and short on fluid. Leg swelling, crackles in the lungs, a raised neck vein, and shortness of breath tell you the patient is wet and overloaded. Once you know dry or wet, the treatment direction is locked in. A dry patient with injury from poor blood flow needs fluid put into the vein, and the usual right answer is a balanced salt solution. A wet patient who is overloaded and short of breath needs fluid taken off, and the usual right answer is a water pill given into the vein. The classic trap is an answer that gives fluids to someone who is already overloaded, or that dries out a patient who is already empty. Match the treatment to the volume status, and these questions become straightforward. Strategy 3 is how the test makes you replete electrolytes, and there are 3 patterns that show up again and again. First, check the magnesium before you chase the potassium. The classic trap is a low potassium that simply will not come up no matter how much you give. The hidden answer is a low magnesium, because the body cannot hold on to potassium until the magnesium is fixed. So when the potassium stays stubbornly low, hunt for the magnesium value in the STEM and correct it first. Second, match the route to the severity and to the symptoms. A mild, symptom-free, low value gets replaced by mouth, while a severe value or one causing symptoms such as heart rhythm changes gets replaced through the vein. An answer that gives slow oral repletion to a dangerously low value, or that pushes aggressive intravenous repletion for a trivial one, is the wrong choice. Third, when several values are abnormal at once, treat the dangerous number first. A high potassium with changes on the heart tracing goes to the front of the line, ahead of a mildly low sodium or magnesium. Always ask which abnormality threatens the heart right now, and stabilize that one before you tidy up the rest. Let us work through our first practice question, and this one is built to test how you classify kidney injury and choose between fluids and diuresis. A 70-year-old man comes to the emergency department after 3 days of heavy vomiting and poor intake. He feels dizzy when he stands. His blood pressure is low, his heart rate is fast, his mouth is dry, and the veins in his neck are flat. His laboratory testing shows the creatinine has climbed from near normal to clearly elevated. The ratio of blood urea nitrogen to creatinine is high, and his urine is concentrated. The question asks for the most appropriate next step. Before you look at the choices, notice every clue here is pointing in the same direction. This is a dry patient whose kidney is starved of blood flow. Read the 4 options carefully and commit to your answer. Then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. Every clue in this stem points to a dry patient. Heavy vomiting, poor intake, low blood pressure, a fast heart rate, a dry mouth, and flat neck veins all mean the kidney is starved of blood flow. The high ratio of blood urea nitrogen to creatinine and the concentrated urine seal it. This is injury before the kidney from lost volume. Second, apply the rule. A dry patient whose kidney is short on blood flow needs that blood flow restored, so the correct next step is to give fluids into the vein with a balanced salt solution. That refills the tank and reverses the injury. Third, eliminate the wrong answers. Giving a water pill would dry out a patient who is already empty and make the injury worse. Ordering an urgent ultrasound hunts for a blockage, but nothing in this story suggests the urine cannot drain. Starting dialysis is far too aggressive for an injury that simple fluids will fix. The correct answer is to give fluids into the vein. Notice how classifying the injury first led you straight to the treatment. Here is our second practice question, and this one tests whether you treat the dangerous number first. A 60-year-old man with long-standing kidney disease has missed several dialysis sessions. He arrives weak, and his heart feels like it is skipping beats. His potassium is markedly elevated. This is the part that should grab you. The heart tracing shows tall, peaked waves and a widening of the electrical pattern. He is awake, and his blood pressure is stable for now. The question asks for the most appropriate next step. The key here is that a high potassium with changes on the heart tracing is an emergency that threatens the heart right now, so the question is really asking what you reach for first. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, protect the heart membrane. When the potassium is high and the heart tracing has already changed, with tall peaked waves and a widening pattern, the very first action is to give calcium into the vein. Here is the part people miss. Calcium does not lower the potassium at all. What it does is stabilize the heart, so the high potassium cannot trigger a deadly rhythm while you work on the rest. So whenever you see those tracing changes, calcium comes first. Then shift and remove. After the heart is protected, you shift potassium into the cells by giving insulin alongside sugar. And then you actually remove potassium from the body with a binder by mouth and, for a patient like this who has missed dialysis, with dialysis itself. Insulin, the binder, and dialysis are all correct steps in the sequence, but none of them is the right very first move, because protecting the heart always comes before lowering or removing the potassium. The correct answer is to give calcium into the vein right away. This is the exam testing whether you treat the dangerous number first. Let us talk about when the question is steering you to call the kidney specialist, because the exam tests this with a recognizable set of clues. First, learn the urgent dialysis triggers as a single memorized group. The classic life-threatening problems that simple measures cannot fix are a dangerously high potassium that will not come down with medication, acid building up in the blood that will not correct, fluid backing up in the lungs that does not respond to a water pill, and the toxins of failing kidneys causing confusion or an inflamed lining around the heart. When any one of these appears in the stem, the answer is moving toward urgent dialysis and the specialist. Second, even short of those emergencies, the exam wants a specialist involved when the cause is unclear or worrying. Think of injury inside the kidney itself with blood and protein in the urine, which points to inflamed filters, or a sudden severe rise in creatinine with no obvious explanation, or kidney function that keeps getting worse even though you gave the correct fluids. When the stem hands you findings that would need a kidney biopsy or specialized treatment, the right answer is to consult the kidney specialist rather than keep managing on your own. Knowing this short list turns a scary question into an easy point. Here is our third practice question, and it is the mirror image of our first one. A 65-year-old woman with kidney injury has been admitted and has received large amounts of fluid into the vein over the past 2 days. Now she is short of breath, she cannot lie flat, and her oxygen level has dropped. On examination, her legs are swollen, the veins in her neck are raised, and there are crackles in both lungs. Her urine output is low but still present, and importantly, her potassium and acid levels are normal. The question asks for the most appropriate next step. The trap the writers are setting is the reflex to keep giving fluids to a patient with kidney injury. But read the volume status. Every finding here says this patient is overloaded and wet, not dry. Choose your answer with that in mind, and we will reason through every option on the next slide. Let us break down this answer. First, read the volume status, because that is the whole question. This patient is soaked. She has swollen legs, raised neck veins, crackles in both lungs, shortness of breath, and a falling oxygen level, all after 2 days of heavy fluids into the vein. Every one of those findings says she is overloaded and wet. An overloaded patient who is still making urine needs fluid taken off her, so the correct next step is to give a water pill into the vein. Now, the key distinction between the wrong choices. Giving more fluid into the vein, or a large salt load by mouth, pours more water onto a patient who is already drowning, and that is exactly the trap, because a label of kidney injury tempts you to keep filling the tank. Urgent dialysis is reserved for fluid overload that does not respond to a water pill, but notice her potassium and acid levels are normal and she still makes urine, so she has not reached the point of needing dialysis yet. Because she is making urine, you try the water pill first. The correct answer is to give a water pill into the vein. This question is the exact mirror of our first one, and reading the volume status is what separates them. Here is a high-yield pearl that ties the electrolyte questions together, and it is all about order. First, magnesium before potassium. When a low potassium simply will not rise no matter how much you give, the answer is almost always a low magnesium hiding somewhere in the stem. The body cannot hold onto potassium until the magnesium is corrected, so you replace the magnesium first and the potassium follows on its own. That same partnership explains a stubborn low calcium, so whenever repletion is not working, look one mineral over for the hidden cause. Second, for a dangerously high potassium, hold this order in your head. Protect, shift, then remove. You protect the heart with calcium first. You shift potassium into the cells with insulin given alongside sugar next, and only then do you remove it from the body with a binder by mouth or with dialysis. The exam loves to offer an answer that jumps straight to removing the potassium while skipping the step that protects the heart. Keep the order straight and you keep the point. Master these 2 sequences and the electrolyte questions become some of the easiest on the test. That wraps up our review of acute kidney injury and the management of fluids and electrolytes for Step 3. Remember the core ideas we covered today. Classify the kidney injury before you treat it, sorting the cause into a problem before the kidney, inside the kidney, or after the kidney. Read the volume status to decide between giving fluids and removing fluids, because a dry patient needs filling and a wet patient needs a water pill. Replete electrolytes in the right order, fixing magnesium before potassium, and for a dangerous high potassium, protect the heart, then shift, then remove. And know the short list of clues that tell you to call the kidney specialist. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.